going to introduce Emily Drake, who is an RN, PhD, and Associate Professor at UVA School of Nursing. She teaches courses in maternal child health and has held a clinical position in labor and delivery for many years. Her specialties include high-risk pregnancy, infant development, breastfeeding, and technology. Her current research is in the area of postpartum depression. She is the author of several book chapters and journal articles. She serves on the National Board of the Association of Women's Health, Obstetrics, and Neonatal Nurses, and is an active supporter of the March of Dimes. She is also a mom to 2 great children, both in college now, so please send money. In her spare time, she enjoys skydiving, skiing down really big mountains, and taking power naps whenever she can. So welcome, Ms. Emily Drake.
Thank you so much. So I'm totally inspired. Aren't you inspired? I love all the singing and the dancing and the poetry and the rap songs and the stories. I'm all worked up. How many of you guys are pre-med or interested in medicine? Okay, anybody pre-nursing? Interested in nursing? Yeah, nursing. I see real nursing. Yeah, interested in pre-nursing. How about anybody doing anything else? Like some other major? Who's some other major? Yay! We need you too. We have not figured out this preterm labor thing. We need all heads in this. That somebody, some engineer, some artist, somebody's going to come up with a solution for this. We haven't made much progress, as you saw. In fact, the problem's getting worse, not better. So I'm counting on you to be a hero in here. Somebody's going to get their PhD and figure this out. I just want to show you where I work. In case you want to come visit me, right there in the School of Nursing. I have been a nurse a long time. This is my graduating class, and I am a double hoop. And this is, University of Virginia Hospital, like my hospital. I mean, sometimes they let me work there. Sometimes, okay. But I'm a labor and delivery nurse. Okay, and I'm all about the babies. This is what I do. My whole career. And what do nurses care about? Maybe you're wondering, what's the nurse's perspective on this? Nurses have a very patient-oriented perspective, and I'm going to tell you some stories about some of my patients. We also take a holistic view about patient care, and we want to know everything about our patients. We want to know where they live, how's their family, what's their community they're living in. We really try to take the big picture on this. We're also very much into health promotion, disease prevention. We like to prevent preterm labor and safety and quality. As you noticed, that the rate is going up, and we want to know why. Certainly having twins, triplets, quadruplets, octuplets are increasing the risk. We're also having a lot of older mothers taking care of pregnant women as old as 54. I know that sounds really old to you. It seems that old to me, but they're a little bit more at risk. Also more infections, more labor inductions. We're inducing labor on women. They want to have a baby on a certain day, or for the convenience of the physician, we may deliver them on a schedule instead of when they want to come. We're also having an increasing cesarean section rate. Did you know that 1 in 3 pregnant women gets delivered by cesarean section? Almost 30% of women are getting a C-section now. And then because we can save these tiny babies, sometimes we're not so worried about them delivering early. We've made a lot of advances in NICU care, but we haven't stopped the problem. So we've talked about these preterm babies, and I'll reiterate what everybody has said. There's really kind of 3 kinds of preterm babies: the very super premature, extreme, or very low birth weight babies that are just 1 to 2 pounds, the ones that fit in the palm of one hand. Then there's the kind of middle preterm babies that fit in 2 hands, the 3 to 5 pounders. And then this group is actually causing more problems lately, and why we're having an increase in preterm birth rates is we're having a lot more babies at this kind of tail end of pregnancy. Pregnancy should be 9 months or 40 weeks, and a lot of people are delivering just like a month early, and that actually causes the survival rates. If we can just get them to 27 weeks, at least the survival rate is very good. There's one with greenies. And we've talked about these complications of very low birth weight. So I'll keep moving. But I did bring some pictures. These are the very preterm babies. Madeline, 300 grams at birth. This baby did very well. Okay, this is now a teenager, an honors student who plays violin. So it's really hard to predict. After 20 years of experience of watching these preterm births, I look at some of these babies and I go, oh, they're never going to make it. Why are we doing everything for them? But some of them do fabulous. And then some of them struggle and have a very rocky course. So, but it's almost like you can't predict. So we have to go do everything for all of them in the hopes. These are these middle preterm babies, these kind of 27 to 30, 32 weeks. They're a little less technology dependent, and they tend to do a little bit better. And then after you've seen those little ones, you see this late preterm infant at 35 weeks, and you say, well, he looks great. He's 6 pounds, he should do fine. He's only in an incubator, no oxygen. But these babies are sneaky. They look normal, but they have a lot of problems, including infection, respiratory problems, and often get readmitted. So they're more at risk. Here's part of the problem is that the brain development at that very end of pregnancy is huge. So if you have the baby just a few weeks early, the brain is much smaller. And if you can wait till 39 or 40 weeks, right around the due date, the brain is much bigger. I think if we tell parents this, because a lot of them want to go ahead and have the baby, it's a developmental task. You get that big around, you want to get that thing out of there. And we have to talk them into kind of keeping the baby in, trying to go as far as they can. Bigger is better. And the Virginia State Health Department has a slogan that says, make mine 39. Try to get your pregnancy as far along as you can. No, are you guys pregnant? I don't know. When you are, try to make yours 39, even though it's hard to be that big. This is one of my patients that was preterm labor, Mrs. Tia. I can't reveal her real name. But she broke her water. She had premature rupture of membranes at 32 weeks gestation. This was a total surprise to her. She had no idea that you could just break your water early in pregnancy. And when she came in, she thought we were just going to deliver the baby. But we didn't. In fact, we put her on bed rest, not because bed rest works, but that's all we had to offer her. And so she was on bed rest for us in the hospital for a month. So stuck in that bed, waiting. It was hard for her. But being in the hospital for a mom, this costs about $250 a night, kind of a high-price hotel, versus about $1,500 a night for the baby in the NICU. So we got her a little bit further along, and she had a fairly healthy baby. Here's another patient, Mrs. J. She came in at 28 weeks gestation. She was in preterm labor. She spent 6 weeks in bed in the hospital with an IV with magnesium sulfate infusing 24 hours around the clock. It's a pretty nasty medication. She felt fine when she came in. She said, I'm having a little cramping, but I feel fine. Then we started giving her this medicine to stop her labor, the tocolytic. It makes you feel like you have the flu, like you've been run over by a truck. And all she could do was lie there in bed. She really couldn't move much. But we did get her pregnancy several weeks further along, and that helped her baby. Our whole goal is to keep these babies out of the NICU. I love the NICU, but we got to keep them out of there. What do we do to stop preterm labor in labor and delivery? We'll give them that progesterone that comes as a suppository or an injection that the patient has to do every week. So that's no fun. The magnesium sulfate, also not fun. It makes you feel sick. We also give another medicine called nifedipine. We'll probably also start some antibiotics. Bed rest, and again, there's lots of research that shows it doesn't work, but that's all we have. and we'll monitor closely. We also give a steroid to the mom. We give it to the mom to go to the fetus. That's an IM, an intramuscular injection. So also not fun. Somebody's got to find a cure for this preterm labor, I'm just telling you, because it hurts. We'll put her on the monitor, and there's some controversy about whether these monitors do anything. It helps us detect contractions. Sometimes these women in preterm labor can't even feel their contractions. They're so mild. So the monitor will help us. But it turned out it isn't the monitor that really helps. When they did the research, it was having daily contact with the nurse, close contact with the nurse, that stopped or at least helped prevent her preterm labor. This is the problem. These symptoms are very mild. Okay, sometimes women say, I just felt a little pressure down below. I didn't know that was contractions. Or a little backache, just a little cramping in their back. I'm like, did this cramping come and go every 5 minutes? It's like, yeah. Or menstrual or stomach cramps and discharge. The cramping may be painful or not, or they may think that it's just a stomach upset. But these can often be preterm labor patients. I tell my patients after they get to be about 20 weeks along in their pregnancy, anything funny between here and here, you need to tell me about anything you feel that. We'll tell them to lie down and rest, drink more fluids. Fluids seem to help stop preterm labor. And to sort of palpate with their hands any contractions they're having. They may be able to feel it better with their hands on the outside than they can on the inside. Have you ever heard of something called Braxton Hicks contractions in labor? Most women get these. They're little mild, kind of warm-up contractions that come and go intermittently during the pregnancy, but they're often confused. Sometimes women think that they're in preterm labor and they say, oh, well, that must just be Braxton Hicks, but it's not. So they need to come in for help and get that evaluation. Here's the rub. We talked about a lot of the risk factors. 50% of the women that have preterm labor had no risk factors at all. They were perfectly healthy. They were doing everything right. And then they just go into preterm labor. We don't even know how to predict this or screen for this very well. And so what we need to do is screen every pregnant woman. We do know twins and triplets. We do know anybody who's had preterm labor before or has any cervical or uterine abnormalities should be screened. Generally, babies are well protected when they're in utero. But any kind of infection in the mom can kind of kick up some preterm labor. So a lot of times we'll treat these women with antibiotics. And if we could take care of these infections before they got pregnant, that would be the best thing. Douching has been associated with preterm labor. So I wish I could get all women to stop douching. You need your normal fluoride. Also, dental health. You need to brush your teeth. I wish I could get all pregnant women to get really good at oral hygiene. Some of the bacteria are in the mouth, around the teeth, may be associated with preterm labor. I wish I could get all women to come to the doctor before they get pregnant. I wish they would come to their OBGYN and say, I'm thinking about getting pregnant. I'm planning on getting pregnant in the next year or so. What do I need to do to get ready? So that we could treat any infections, so we could screen them for all these other things, get them in the top health conditions before they get pregnant. Get them on folic acid. We try to talk to women about stopping smoking or at least decreasing their smoking behaviors. We try to get women to get their nutrition in order before they get pregnant. If we can get the substance abuse down, maybe not stop would be great, but if we can get them to decrease their use of substance abuse, particularly crack cocaine, that's the bad one, and stress. It really is a lot of research about life stress or chronic stress and preterm birth. Also, there are lots of studies linking preterm birth. So if we can help women get into a safer relationship or a safer environment, we may be able to reduce some preterm labor. Oh, that's a cute baby. Who's that? That's my baby. I mean, that was a while ago, right?
Yeah,
Okay.
like 20 years.
I just want to put in a little plug for nursing research. Nurses do research. Did you know that? And we have come up with a lot of strategies to teach symptoms of preterm labor, to help in communities, and then help women seek care and respond to care better. Nancy Jallow down on the Eastern Shore, Virginia, has done a lot of research on stress reduction and preterm labor. Even telephone support, having somebody to call, being able to call a nurse on the phone can help reduce preterm labor. We also do research on the effects of bed rest, we found is not effective, and the effects of the preterm birth on everybody in the family, not just the mother, but also the father, the siblings, the rest of the family. And also on follow-up, Mary's going to talk more about that. And I've got to put a plug in for breastfeeding. Especially if you have a preterm baby, breast milk is the best for that baby. It really helps reduce infections and other risk factors. So for women at high risk for preterm labor, we want to see them more frequently, more prenatal visits. And again, I'm putting in a plug for being able to